things. There we go.
Okay. This one's pretty quick, but it was a coronary case from last week or 2 weeks ago. And it's just basically a show and tell. So if you follow the LAD, the patient was diagnosed at an outside, I guess he had a cath at an outside hospital, then he was sent to our institution, and with the reported history of a LAD to pulmonary artery fistula. So you follow the pulmonary artery, and now we're the LAD here, interatrial groove, where it kind of like looks kind of small. I don't think this patient got nitroglycerin, so the vessels look small here in general, but so this is the groove between the interventricular groove there. And then if we go more superiorly, you can see this branch. This is a branch of the LAD that comes up, and you can see the fistula with the pulmonary artery. So it's really not something I see, and unclear what the reason for this is. My gut feeling is that it's iatrogenic, but we don't have any reported history, because it could be the other possibility is congenital. And then the other thing to question is there coronary steal or steal? This is the LAD distal to that fistula is kind of small.
So Peter, how would that be congenital? I mean, sorry, you said iatrogenic.
Oh, from a cath. So if they injured the vessel with the wire.
Oh, okay.
Yeah. But I am not sure. Have you seen that before, Jeff?
I have not.
Yeah, I hadn't either.
That's
we've seen these quite frequently. This is Misha at UCSD. Seth usually just sends them out when he sees them just to show us, but he says he sees them quite frequently. I presume they're congenital, but we do see them quite frequently when we're looking.
Okay. Sorry. And then the other case is a vascular and lung case. So we'll start off with the pre-surgical CT. It's a chest, abdomen, pelvis. This patient has a history of, I think it's a 35-year-old lady with a history of Marfan's, and then she has obviously a very large aneurysm of her descending aorta, and there was a dissection as well here. So this is pre-surgical. She got an open repair of her descending aorta, and then this is one of the I guess 1 or 2 days post-op. So there's a graft in there, and this was done without contrast, but there's a aortic graft in here, which is hard to see without contrast. There is some fluid collection around it that ended up getting bigger. But the interesting thing is this finding in the lung here, in the left upper lobe. There. So here's what it looks like in a radiograph. I only included one, but there are multiple radiographs. And then so that was on April 2nd, and then about a week later, actually, yeah, so about a week later, this, I think it was read as a pneumonia. It's just persistent. And then And then I read a CT of this last week, a week after that, and I noticed the left upper lobe was taken out. So I went back and looked at the charts. This is a lung torsion, and here's the op report. So the thoracic surgeon had to go in, and the left upper lobe was torsed and infarcted and had to be resected.
How did they think that caused the torsion of the upper lobe?
How did it happen? I'm not sure actually how. It must have happened because they did a thoracotomy back here,
Mm-hmm.
and to get to that descending aorta. But I am not sure exactly what.
Yeah,
what was.
I mean, I think they would just collapse the lobe to get it out of the way.
Yeah.
But if they were
Actually,
operating on the descending aorta, they might have resected the pulmonary ligament and freed up the left lower lobe. Maybe that allowed things to rearrange, but
Yeah. I actually need to. That's a good point. I need to go back and read the initial surgical report for the vascular surgical report and see what they did and get any clues from there. This is the most recent scan post-op. She also has this fluid collection encasing the descending graft here, which is also not completely clear. There's no extrav or anything in there. It could be maybe they injured the thoracic duct, so it could be chyle or it could just be fluid, simple fluid. And this is the lobectomy here. That's it.
Very cool. Has anyone else ever seen a torsion after aortic surgery? I have not. That's interesting. Okay. Let's see. David, you want to go?
I can take them.
David, are you there?
I'm here. I think I'm here.
Oh, I hear you now. Do you want to show some cases?
Yes. So let me get my screen ready here. Okay. So I'm going to show some PowerPoints here of some old cases that I digitized, and these cases all have the same diagnosis. So here's a woman, I think she's about 35, and she has a blob down here in her right base, some smaller blobs up here, and a big blob on this side. And then some of this anterior stuff on both sides is showing up here on lateral view. And I hope I am capable of advancing these slides here. Let's see. And here's what things look like on CT. Here's this big lesion anteriorly on the left, and almost the same size one on the other side, and some lung windows to show you that there are actually several lung nodules. So that's one case of this diagnosis. And here's another person here with radiographs in 77 with lots of ill-defined lung nodules, and then some clearing in 78. So these are really ancient cases. Of course, they're from before I was born. And then here's another person with the same diagnosis and a bunch of shaggy lung nodules all over the place. So we have a theme here. Has anybody cracked the code and recognized this disease? Here's what that CT looks like in that person with this ancient CT scanner. Nodules with actually fairly well-defined margins in lots of locations here. Quite big nodules here in the upper parts of the lung. Here's another person with the same diagnosis, nodules all over the place, ill-defined mostly, varying shapes and sizes. Lots of nodules on CT as well. Another person with big nodules, ill-defined, asymmetric, and this is what it looks like on CT. These are getting kind of stellate, these nodules with ragged borders. Another case, ill-defined nodules all over the place. Some cavitation as shown on CT up here, right upper lobe. Down here, a somewhat lower lesion. Diagnosis?
They're immunocompromised or not?
No, not immune compromised.
Not.
Not immune compromised.
Yeah, some of these predate HIV. They seem to be young people and they seem to get better.
Yeah.
And there are some male, some female.
They are young people for the most part, 20s and 30s.
I would wonder about some fungal infection, although out in your part of the neck of the woods, I mean, other than cryptococcus, and why would so many people have it? I don't know. That one has lymphadenopathy. I mean, sarcoid is a thought. That one, but the cavities are unusual, and the roundness of them is unusual as well.
Right.
Wegener's?
Okay.
Yeah, although the lymphadenopathy is not that common, but it could occur.
Okay. Hilar and mediastinal lymphadenopathy.
Yeah, I wonder about some outdoors acquired infection.
Got it. People shouldn't go outdoors. They should just stick to indoors, and for exercise, they should use the remote control on their TV. Okay. And then here's an earlier exam on this person a few years earlier, and you can see at this point it was mostly just lymphadenopathy. We did have some lung lesions, but not as dramatic. So these are all cases of sarcoid.
Wow.
So this is nummular or airspace sarcoid, whatever you want to call it, with these usually ragged nodules. Usually these people are remarkably symptomoposic. They don't really have very much symptoms despite the dramatic radiology. In one case, the case that I started with, it was actually a necrotizing sarcoid. So these big nodules here on biopsy had some necrosis in it. So they weren't just non-caseating granulomas, there was caseous necrosis. So sarcoid doesn't have to be non-necrotizing in it every time. It can have some necrosis as part of it. So these are cases of airspace sarcoid, and the reason these cases are old is because they're infrequent. And so these are the cases that I have saved over the years, and some of these go back to North Carolina. Most of the people there in North Carolina who have sarcoid are Black. And it is said, I think, that nummular or airspace sarcoid is more common in Blacks. But it's hard to know. You really have to get the population base to know that. You need a denominator to make that determination. So all cases of airspace sarcoid. And the first case with some necrosis.
Wow. The necrosis is very interesting to me because I had never seen that before.
Right.
Yeah,
and the
interesting.
cavitation.
I don't see this manifestation nearly as I know. I mean, it's interesting that these are all old cases because I mean I've seen a few cases, but the majority of cases of sarcoid I see have the smaller perilymphatic nodules.
Yeah.
And I don't know if that's a demographics thing, if something's changed over time with whatever antigens are triggering this, or we're just it's so rare you just have a major selection bias in your nice collection here.
Well, I mean, these cases were selected because they are dramatic cases, and so yeah, this is selection because these are unusual, and this is a career-long accumulation of these approximately 8 or 10 cases. Okay, guys, just presenting this wore me out, so that's all I have today.
All right, that's great. Okay, let's see what I got here. Okay, so I have 3 cases. This is kind of an interesting case and something I have not seen very often because it's unusual to get kind of this kind of longitudinal imaging. So this patient carries a diagnosis of COPD. He's a recent up till now recently smoker, about 20 pack years. And let me get the relative times here. So I'm going to show you 2 frontal radiographs. And you can see this is the older one here. It looks fairly normal. This is the more recent one, and you can see a couple of things. First, you'll notice there's been a little shift of the anterior junction line. You also see there's some now scalloping of the diaphragms, and we have pretty large lung volume. I don't have an old lateral, but I do have a new lateral. So this is the new lateral. And I'm sorry, I don't have a new lateral. This is the old lateral. You can see decent lung volumes, maybe a little expansion in the retrosternal space. So he got a CT scan, and then here is his old CT scan. So if we look at his old scan, you'll see he has some mild central lobular emphysema. And then as we go down, not a whole lot going on. So these are about 10 years apart. And then here is the more recent CT, and you can see there's been progression of the emphysema. Let me just make it bigger so we can all see. See if it's still not very severe emphysema in the upper lobes. But as we go down, you'll notice the superior segments of the lower lobes look a little too dark, and the vessels are starting to get small. And as we go further down, we're seeing less and less architecture in the lower lobes, especially out in the periphery. You see very small vessels and absence of other structures. A little bit of bronchial wall thickening. And then at the very base is, again, just sort of expanded out there. Here is a sagittal showing you that difference in lung density. You can see it's blacker down here, and you can also see there's now sort of getting a little barrel chested flattening of that hemidiaphragm. So this is a 10-year or so progression of emphysema that's starting to look like alpha-1 antitrypsin deficiency, or at least it's panlobular. It could all be smoking related. I don't have confirmation, but he's only in his 50s, so it's possible it is alpha-1. But it's just a very subtle progression, and at least initially, but recognizing sort of this density and the difference in vessel caliber. You can see on this nice image here, these upper lobe vessels are a lot juicier than the lower lobe ones at similar distances from the pleura, and it should be the exact opposite. And then here's the coronal of that scan as well, just showing you the relative hyperlucency of the lower lobes. So possible alpha-1, but definitely panlobular emphysema progressing or developing over a 10-year period in a patient with diagnosed COPD that's getting more symptomatic. And so I actually kind of like the radiographs better for showing the hyperinflation. Again, that's the old one. Here's the newer one, and you see that scalloping down here, which sometimes is a clue. I wish I had a new lateral, but I don't. So that's the first case.
And Jeff, he's not shooting up ground up Ritalin tablets.
Nope. Nope, doesn't use it. Just drinks beer and smokes cigarettes. This is an interesting case. So this patient has a history of alcohol-associated liver cirrhosis and developed a pneumonia at this time. And you can see there's some volume loss and there's some consolidation in the right upper lobe. There's a mass here at the level of the right hilum. And let's see, at that time, this patient had a CT scan. Let me make sure I get the right one. Yeah, so here's a CT that's contemporaneous with that radiograph. And you can see there's some background emphysema. And on top of that, let me move it around here, we have this area of consolidation with a little bit of central lucency in that right upper lobe. And then what's kind of interesting here is this ground glass has this very nice horizontal line. Almost makes you wonder if some of that's edematous alveoli, why it's, or there's some kind of, I don't see a fissure there. It doesn't seem to follow. So anyway, there's this consolidation and ground glass in that right lung there. And not much else going on in that area. And then, so he didn't respond to conventional therapy. They've re-imaged him, and you can see now we've developed a cavity up in here. That hilar thing looks like it's gone, but now there's a new area of rounded consolidation out there. He now has a left effusion. So he had another CT scan at this point, and you can see he now has this big cavity up here, and there's this intracavitary debris that looks like lung tissue that's kind of sloughed and adherent hanging out in that cavity. And then there's a new cavity more inferiorly with a halo around it, a very thick wall, not a lot of intraluminal stuff, and then these nodules of consolidation. And then this left effusion is probably related to his liver disease, and he's spilling a little bit of crud down here in the medial basal right lower lobe. So he got a workup, and they got a lot of aspergillus in his sputum. So this is presumably an aspergillus infection, almost acting like angioinvasive, but not quite, because he's not immune compromised enough. But because he is cirrhotic and drinks a lot, he is at risk for aspergillus. And so this is probably not really a chronic necrotizing, because it's not chronic, but sort of a trying to be invasive aspergillosis that's not, but it's caused a necrosis, it's caused sloughing of the dead lung, but it's still ongoing here with this area here. So not a common infection in well, I guess we shouldn't call them incompetent, but not the classic infection in this demographic. But this, yeah, I was talking to the infectious disease doc, and he's definitely immune compromised enough to get this related to his chronic liver disease. But it's kind of a neat evolution. It went from sort of a acute non-cavitary infection to this cavitary infection, but it was probably starting to think about necrosing here. Not quite a bird's nest, but it kind of gives, it's a little reminiscent of that, with that central sort of less dense stuff going on. And I just thought this was kind of odd too, and I wonder if some of that was just stuff layering in that lung and not truly part of the infection.
He wasn't hemoptysizing at that time or anything?
No, not that I'm aware of.
And Jeff, what happened to that central mass?
Well, let's see. Let's go back to that CT.
Just consolidation, I guess.
I think it was just all of this. I think it was all of this consolidation in the perihilar region, fooling us right in here. You can see it kind of extending there. So no real lung mass there. So an unusual case of aspergillus.
Is that basically just the middle lobe that's
Yeah,
squished together?
I think it is, because there's the horizontal fissure pulled up. So that's probably what it is. We go to the coronals on that CT. You can sort of see it there a little bit. Yeah, it's a weird one there. I think it's just superimposition. All right, and then this last case is kind of a cool case. So this guy is a diabetic who had a kidney pancreas transplant about 8 years ago, and he came in with fever, cough, and a rash. And you can see on his chest radiograph, he has this consolidation in the basal left lung. I think we have a lateral. There it is in the left lower lobe. So he was put on antibiotics for community-acquired pneumonia. But then with this rash, I can show you a picture of it. You can see he has all of these pustular lesions on his leg. And then here is a picture of his chest. And you'll notice there's little dots in the middle of them, best you can see. So if you haven't seen this, some of you on here may not be old enough to have ever seen a case of this in the wild, but this is varicella. So he has disseminated varicella zoster. But at the time, so he did have a CT of his chest. This was still presumably a community-acquired pneumonia, given it's just consolidation and a bunch of nodules. Maybe did he aspirate or something? There's a lot of stuff in the lower lungs and a little bit of junk here in the right lower lobe. But he wasn't responding to antibiotics, so they actually did they got a piece of tissue of this. I think it was a transbronchial biopsy, and unfortunately I don't have the pathology slides, but our pathologist signed it out as varicella pneumonia. It has very characteristic appearances on anatomic section on histopathology. So this is a case of varicella pneumonia presenting sort of as a mass-like consolidation. So a couple take-home points. We all learned in residency, when you see like diffuse tiny little calcified nodules that in the differential is old varicella pneumonia. I don't think I've ever seen a real case of that. I mean, I know it's been described. More often I see that with old histo when I see a bunch of tiny calcified nodules. And that, and then the argument that, well, viral infections don't cause lobar pneumonia, which I will say is nonsense, because I've seen plenty. This is one example, sort of a lobar-like consolidation. I've seen adenovirus do it as well. And sometimes with viral infections, it's tricky though, because you have mixed flora. But this is, I mean, this on histopathology had all the changes related to varicella pneumonia. And so treating him with antiviral therapy, and he got better from this. But we don't see it very often. I mean, varicella is not very common anymore because it's pretty much all children are uniformly vaccinated. And most people who get varicella these days are the small number of unvaccinated people who usually just get cutaneous involvement. But he's a transplant recipient, so immunosuppressed patients, even if they're vaccinated or have had varicella in the past, are at risk for either recurrence, like because it hides in the dorsal root ganglia and it can reemerge, hence the new shingles vaccine that's offered in the US, or it's a new infection in someone who's immune compromised. So two interesting infections, ones I would not expect to see in immunocompromised patients. And that is what I have this week. I'll see if anybody else has joined us. If not, we'll just have a short conference today and resume next week. I know everyone's been very busy and staffing is challenging at a lot of places, so I appreciate everybody taking the time to be here. All right, well, thank you very much.
Thank you, Jeff.
Thanks,
everyone.
guys.
Take care. Have a good rest of your week.
You too.